specifically the lung series, and we've been running this oncology for non-oncologist program for a while, but with different sort of focuses. So with breast and prostate as well, but to the person of Prof. Jane Efriye-Mensah, who is the chairperson for this session. She is a consultant pulmonologist based at Kolebu Teaching Hospital and is the current president of the Ghana Thoracic Society. So without much ado, I will hand over to Prof. to kick.
Julia.
Yes, Prof.
Yeah. Sorry, I lost you briefly. Were you saying I can go ahead and introduce the program?
Yes, please, Prof.
It's otherwise, if you can allow me to share, but
see, I can share from my end.
Okay, let's see if I can. But let me start off by saying a good afternoon to all and to listen to this novel series on. This is a brilliant idea, and we are happy to have you here this afternoon. My job this afternoon, is to introduce this program, what we are calling for non-oncologists. Maybe sure if my slide is showing.
Yes, Prof, please. It's showing if you could put it in slide mode.
Sorry, Julia. I don't know. So, Julia, I am kind of struggling to put it in a presentation mode. If you have it.
I do have it. Let me share.
Okay, let me stop sharing.
This is on here. Thank you.
So I think I have an issue here. Okay.
Prof, please, can you see?
I am not able to see, but a moment. Okay. I think I may have done something, but I don't know what it is. Okay. So I would just talk along, Julia. I'm not able to see your slides. But again, good afternoon to you all. As I said, this series, let us understand why we are doing this series and why we want to engage everybody. So my first slide is showing and asking if the pictures alone speaks for itself. We see two images. One is a chest X-ray, one is a CT, malignant one, of course. And it may present as a mass, as seen on the chest X-ray, very subtle, or it may present as an area of consolidation, also seen on the CT scan. Now, the big question is lung cancer a problem in Africa or in Ghana, for that matter, I would want to say that, yes, there are increasing reports across almost all countries in Africa, particularly West Africa, suggesting.
Please, I think the slides are not moving. So if you could just tap on the slide. Your slides are showing now. Yes.
Oh.
Yes. Please, Prof.
Okay. So thank you.
At the top of the screen, the slide show at the top, from file, home, inserts, the slide show right at the top. So, yeah, the top, then from, yes, please, Prof.
Okay, thank you. All right. Thanks for the IT. The image I was showing, real view to what lung cancer is. Now, I asked the question that, is this a problem in Africa or in Ghana for that matter? And what I can say is that across almost every country in Africa, diagnosis of lung cancer. And it is worrying. We are also seeing a similar trend in Ghana. The issue in Africa, of which Ghana is inclusive, is the lack of documentation and appropriateness of data. Come to think of the fact that we have significant challenges even with diagnosis. So a lot of our cases may be suspected, but probably were never confirmed as not focused on infectious diseases in our part of the world. Yes, we are. And one of the great chronic lung diseases is TB. We tend to say that this is very endemic in our country, that we contribute 23% to the total global cases. And in sub-Saharan Africa, TB seems to have the highest burden. In Ghana, yes, we are not free from that, although we are not the highest WHO data in 2023. We have noticed also that even though we have focused so much on infectious diseases, there's a rising mortality from non-communicable diseases in Africa. And the figures are, again, stunning, quite a high amount. And about half of these are attributed to Ghana. I'm sure the seasoned speakers will tell us about numbers, but I can, on a rough estimate, we in Kolebu, probably the respiratory clinic, we have documented over 250 cases. And this is exclusive of those that may have had diagnosis done from other doctors and may never have way. So these are just very minimal figures, I would say. Answer is, if we are recording these numbers, it is very worrying. And of course, no one gets much settled with hearing such things. And especially when a patient, but for the risk factor that is known, we don't seem to have a significant share of that, and that is tobacco smoking. So we are here because these are the characteristics of lung cancer. Very merciless tumor. It is known to be the leading cause of cancer mortality, even though it's second to prostate and breast prognosis. And it's one with least curative potential. Novel medication rates for lung cancer are also very disappointing, despite all the upscaled research going on. Majority of the cases that we are seeing always come in stage 4, and that's over. It is a disease that mostly will remain asymptomatic until they present very advanced. We have many confound tricky of our quest to diagnose lung cancer. Almost every abnormal chest image in our environment just has one acronym that goes for it, and that is think TB and nothing else. And this is really a problem. We are also concerned because we are diagnosing more cases at the tertiary facilities. We have very little association to smoking, so present very late, and some may not even get diagnosed at all because probably smear negative. And we have some who may also make it in a very difficult way, struggle to make it to the tertiary facilities to go through diagnostic procedures, only for us to lose them just when the result is ready. Improve this. How can we practice? Then we realize that we cannot sit at one place, especially the tertiary or the diagnostic facilities, which are very limited in any case, and wait for patients to reach us. They always come in late. So we thought that it's a good idea. We need to engage with our dear colleagues at the community level who see these patients first and foremost. We need to let them be aware that there's something called lung cancer. We need survival. That's if only ways. Don't waste time going through referral along the cascades of the health system. That really wastes patients' time and leads to unfortunate death. Talk to non-oncologists. We want to create awareness. And at the end of the day, I'm sure after our seasoned panelists give us all that they have to tell us, we'll be able to talk together, discuss, and see how best we can improve lung cancer care. All right, I hope I was heard.
Yes, please, Prof. Prof, just
just go straight ahead and we will invite our we will invite our first speaker, and that is Julia. Can you share the program, please?
Yes, please.
I'm trying to pick it up.
It's Dr. Vishnu.
Yes, I'll be happy if you share it with me. That is Dr. Vishnu Abayate. Vishnu is one of the pulmonology fellows in training, very interested in lung cancer diagnosis of lung cancer as well. Vishnu, you're welcome. Can you share your slides? Please.
Thank you, boss. Good afternoon to everybody. I hope you can see my slide.
Yes, we can.
Everybody, and welcome to this afternoon's webinar. So my task will be to talk about hearing a disclaimer from AstraZeneca, and to add that this is an educational session. It's not a promotion And the disclaimer says that AstraZeneca does not advocate the use of it. It's not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. AstraZeneca makes no representation, assumes no responsibility for the accuracy of the information contained in this material. AstraZeneca is not responsible for any liability, loss, risks, personal or otherwise, which is or may be in any of the information contained in this material. So if we look at the epidemiology of lung cancer, we look at the pathogenesis, the types of lung cancer, and briefly mention the lung cancer stagings. Okay, so I think Prof. Fimis had already passed some comments on lung cancer. And the reason why it's important for us to be aware of lung cancer is that it's the leading cause of cancer death in the world. Okay, and globally is the second most commonly diagnosed cancer. That's if you combine published their statistics and indicated that in that year alone, 2.2 million new cases of lung cancer was diagnosed, and that same year they recorded 1.8 million deaths. So if you just compare the numbers, 2.2 million diagnoses and 1.8 million deaths, and the reason why you can look at the pie charts. Okay, you can see the majority of majority of the patients are presented at advanced stages. So about 57% of patients in this epidemiology study presented at the time that they had distant metastasis. And we know that with cancer, once there is metastasis, then prognosis is poorer. Even with lung cancer, even if you are stage 1, which is one of the early stages, prognosis is so poor as compared to other cancers like breast cancer. So for instance, if you take stage 1 lung cancer, cancer in stage 1, you are looking at over 95% survivor. So it is very imperative that we have this awareness. And I mean, if there are a lot of people talking about the cancers in their specialty, and you decide that you're not going to talk about yours, in the end, a lot of people may forget that lung cancer, even though in the books it may say that it is not common, to pick them early and also improve the survival associated with the lung cancer. Okay, it's also been shown that it's common in areas with high human development index in Western Europe, in the United States, and Japan. And this could be because in those areas the prevalence of smoking is very high. So this is a graph of the world which is showing the incidence of various cancers. And if you pay attention carefully, you will see that for men, the incidence of prostate cancer is quite high, but then lung cancer comes in when you come to North America, Europe, and some parts. The incidence of liver cancer is the highest in men. When we take a look at the female cancers, obviously the whole map is pink. So you know that breast cancer in terms of incidence is the highest. Then you have some areas of cervical cancer, and you have just a small area where lung cancer is. So if you compare this map, just take a mental picture of this map as compared to the next one, you will see that suddenly you see blue everywhere, and blue represents lung cancer. Okay, blue represents lung cancer. So you can see that lung cancer mortality in men is number 1 almost everywhere. As of the endemicity of hepatitis B. When you come to females, you see that still breast cancer is number one in a lot of places, followed by lung cancer. Then you have cervical cancer in some areas. So in Africa, yes, it's usually, if you look at the data, it's perceived that the burden of cancer is not too high. But then we know that it is rising as a lot of the developing countries are picking up the habit of cigarette smoking. In Ghana, the Globacom statistics in 2020 said that there were about 2.2 cases of lung cancer in all new cancers that were diagnosed. And it was listed among the top 10 causes of cancer mortality. Some few studies have been done, and one of them, formal studies that in terms of giving us information about the epidemiology of lung cancer, was done by our chairperson for this occasion, Professor Fiemesa, in 2023, where they look at new cases that came to the respiratory clinic over a 3-year period. And they found that of all the new cases that they saw, 12.4% of all new cases seen at the respiratory clinic had a histologically confirmed diagnosis of lung cancer. I'm placing emphasis on histologically confirmed diagnosis because, as she said in her introductory remarks, some of the patients may have had imaging, may have not come in early, so probably the diagnosis. So it's very likely that this number can be higher. And that is the reason with respiratory symptoms. Okay. And in this study, as compared to dominant in how they call it, males than females, in this study, they found out that majority of the patients, about 57.8% of the patients, were women. Okay. And you will see that it follows that from that, predominantly 61% of the patients didn't smoke. Okay. I know that from how do you call it? Medical. I mean, I was kind of, and we see a lot of lung cancer patients. And I realized that no, if we have at the back of our mind, we may not pick a lot of cases, because once you come, we are coffee, they ask, oh, do you smoke? You don't smoke, then we say, oh, I mean, it's not likely to be lung cancer. Let's think about TB. So we should know. And this is why I think that this study is 1% of patients who were diagnosed didn't smoke. So if you are waiting to get a history of smoking so that your index of suspicion will increase, then you are going to miss a lot of patients who present with lung cancer. Unfortunately, and just like the global picture I shared, majority of the patients presented in stage 3 and stage 4. And among all the histological subtypes, both adenocarcinoma was common in smokers and non-smokers. Surprisingly, even though most of the patients presented in clinical stages 3 and 4, I mean, testing for mutations like EGFR and ARC were largely absent in the study. Okay. Of the patients who took part in the study, the clinical stage, as Prof said, over 80% of the patient, 87.5% of the patient presented with you can do, but then there is some hope. I mean, we have some, you find some mutations, then such patients may benefit from a targeted therapy. And from the table, once again, you can see that females, there's predominance of females in the study. And let's move down to the age. So I want us to pay attention here that globally, when we talk about the peak age of incidence of lung cancer, we are looking at the fifth who will be diagnosed with lung cancer with more than 65 years of age. But in the study, it's found very important. And and 60. Okay, so we should know that yes, lung cancer is likely to occur in the elderly, but we are having cases, our index of suspicion will have to be very high. And my other colleague will take us through the things we should look out for and how we approach. Now, from the epidemiology, we'll just look at the cancer that occurs in the main bronchi all the way to the alveoli. So once you think about lung cancer, you are thinking about tumors that are starting from the main bronchi all the way through the lobar bronchi, segmental bronchi to the respiratory bronchioles, the alveoli, and also the surrounding connective tissues. And with cancers and squamous cell cancers, they tend to be centrally placed, whilst your adenocarcinomas tend to be peripherally placed. Okay. I mean, lung cancer is not too different in terms of the cell biology. Okay, so for cells to be able to undergo there are certain things that they are supposed to have, what we call the hallmarks of cancer. So first, they should be able to sustain proliferation. So the cell should be able to continue replicating itself. Because if the cell cycles and that's the end, then the immune system will be able to contain the cell and it will not be able to become cancerous. Okay, they should be able to resist programmed cell death. Okay, if the cell multiplies and is still under the control of programmed cell death, then they will die. Once they die, then cancer cannot continue. Then as the cell multiplies and they increase in bulk, they usually will outstrip their blood supply. So they should be able to induce angiogenesis so that they will create new blood supply to be able to continue the cell proliferation going on. Then we'll be able to continue the invasion and the metastasis. Okay, so these are some of the other things that they should be able to do, is that they should be able to go to evade the tumor suppressor genes, and they should be able to sustain the replication so that the replication continues and it's not obtain all these hallmarks, the cell can continue proliferating and becomes a cancerous cell. Okay. Just like in most cancers, the pathophysiology of lung cancer is very complex. I know we always say that, about 80 to 90% that cigarette smoking has a strong association with lung cancer, so it may be the cause of lung cancer. Them to develop lung cancer. So it still tells us that there is some other factors that may come into play, and some of these factors has to be genetic susceptibility to some of the carcinogens. So, for instance, it's been shown that if there's a family history of lung cancer, your risk of developing lung cancer is twofold. And those who have the inherited cancer syndromes, they also have increased risks of getting lung cancer. So there is some genetic basis or genetic mutations working together with the carcinogens, which promotes the tumorigenesis. So yes, we think that cigarette smoking is very important in the pathophysiology of lung cancer. But as it is now, we still don't understand everything completely about lung cancer, develop the lung cancer. And through some molecular studies, some genetic mutations have been identified. And the common ones are the P53, BCL2, MYC for small cell lung cancer, then the EGFR, the CRAS, and P16 for non-small cell lung cancer. Okay, so I mean, this diagram is just representing most of the things I've said. So you see that they come in together. When you are looking at the smoking associated one, cigarette smoke contains a lot of carcinogens, which cause some changes in the DNA of the epithelial cells of the respiratory tract. These tumors start, they are able to continue the replication without any control. Then they form clonal cells. Then the proliferation is sustained. They create new blood vessels, are able to metastasize for smoking associated. But for other tumors, especially some adenocarcinomas, yes, we still have identified some risk factors, but it's not as clear as the cigarette smoking. Okay, so for those ones, yes, we may not really know what really is driving those, but then they will develop the genetic changes, the cells become dysregulated, then the tumorigenesis continue, and they also go through the process. Okay, and this also represents that once the tumor is confined, then it is early. So then treatment surgically, you can go in, take out the whole loop. But once it comes advanced, it is spreads to the opposite lung, then you are in advanced stages and the prognosis become poorer. Okay. So in terms of the molecular basis or changes, one key mutation that we need to keep in mind when we are talking about, especially adenocarcinomas, is the epidermal growth factor receptor, the cell proliferation, and this is some other receptor tyrosine kinases like the insulin growth factor can also have alternate pathways where they can activate the P13K, ALT, and mTOR pathways, and also the RAS-RAF MEK pathway. So once they call the cell proliferation, there is angiogenesis, then you have the procedure going on. And the understanding of the molecular basis of the lung cancer is important because it provides avenue for targeted therapy. And it is through this things like the EGFR, ARC, and the rest. Okay. So this table is just giving us a summary of some of the common mutations that usually you find in lung cancers. Okay. So if you take, for instance, non-small cell lung cancer, most of the cancers really you have the P53 mutation, and it's estimated to be the commonest mutation in most lung cancers. It usually ranges between 70 to 75% of lung cancers. Okay, there is some that think talk about the Nuxin two-hit hypothesis, that they think that for the tumorigenesis to go on, you need two mutations. So you need a mutation in a tumor suppressor gene like the P53. Then you need another mutation in a proto-oncogene like the EGFR. So they feel that once there is one mutation alone, it may not be able to sustain the proliferation and the continuous cell division and the invasion of the apoptosis and the rest. So some hypothesis is that you will need to. So if you have the P53, then you may have some other associated mutations like the KRAS, BRAF, EGFR. Okay, and let's note that in the adenocarcinoma type, we have about EGFR, especially based on the location. So it's estimated that those in the Asian region have about 50% mutation in the EGFR, while those in Africa have between about 20 to 35% mutation. And it plays a key role especially when you identify the tumors at a later stage, there is targeted therapy available that can help improve survival of the patient. Okay, and the pie chart is basically just showing us the various mutations, and you can see that still there's a significant mutation that we still don't know about, but then you can see the EGFR is there, the ARC is there, then the KRAS mutations are also there. I mean, usually when it comes to the types of lung cancer, yes, we broadly is divided in small cell lung cancer and non-small cell lung cancer. And the small cell lung cancer basically has to do with the size of the cells. When you look at it under the microscope, they are very small size, in what the so-called old cell. Okay, they are very small. They look like an old cell when you look at the cells at the microscopes, under the microscope. Then you have the non-small cell lung cancer. Okay, and in terms of percentages, yes, small cell lung cancer usually forms about 15% of lung cancer, and then the non-small cell about 85%. And further, you have 5%. Then large cell, basically as the name goes, you have larger cells, okay, about 10%. Then you have other types that arise from the connective tissue, the blood vessels. They form about 3% of lung cancers. So when you compare small cell lung cancers and non-small cell lung cancers, as mentioned earlier, the prevalence of small cell lung cancer is approximately 15%, while that for non-small cell lung cancer is about 85%. And I already said that the cells are round, small, and they look like old cells. Okay, while the non-small, they are larger and are very fast growing. So most of the time, at the time of presentation, they would have already spread to other parts of the body. And whilst relatively compared to small cell lung cancer, for the time you are more likely, okay, as the statistics showed, non-small lung cancer, most of them usually present at advanced stages. But then if you compare to some small lung cancers, you are more likely to find it localized at diagnosis as compared to some small lung cancers. In terms of smoking association, small cell lung cancer is significantly associated with smoking. Some of the estimates put it as high as 98% of small cell lung cancers are associated with smoking. In non-small lung cancer, yes, your squamous cell is associated with smoking. Then adenocarcinoma can occur in non-smokers, and that's shown in the study by Professor Fiumensa. 61% of the patients who were diagnosed hadn't smoked. And small cell lung cancer tend to be of rapid onset, okay, and they respond to chemotherapy and radiation, and rarely, because most of the time, by the time you be diagnosing them, they will be spread. So rarely the surgery is used. But for non-small cell lung cancer, most of it, they are localized. You may find it more localized than small cell lung cancer. And the options for management are chemotherapy, radiation therapy, and immunotherapy. Generally, lung cancers have poor prognosis, but small cell lung cancer is poorer in prognosis than the non-small lung cancer. It's also small cell lung cancer is associated more with paraneoplastic response to chemotherapy. There's often a relapse, whilst non. At time of diagnosis, it's always important to try and classify stage the cancer. At Kolebu, we have a multidisciplinary team. So most often at the multidisciplinary team meetings, we all look at the images and we try to clinically stage them. Okay. And the staging is usually done using the TNM classification. So TNM basically you are looking at the primary tumor, and we are looking at the original lymph nodes. And T, basically, we are looking at the size of the tumor. Okay, so what is the size of the tumor at the time of diagnosis? Has the tumor invaded surrounding tissues? Okay, so you note that. So for instance, if you have a tumor that is more than 7 centimeters, it has invaded the mediastinum, then you know that, okay, you are dealing with T4. So you know that. Then you come to the original lymph nodes. Is the tumor, has the tumor spread to the peribronchial lymph node or the lateral lymph node in the hilar region, or the tumor has spread to the supraclavicular lymph node or to the lymph node on the contralateral side. So all this will make you classify whether it is N2, N3. Then you come to M, the distant metastasis. Then you can break it down further into M1A, M1B, M1C, and even various sub divisions. So this is just to let us know that the TNM classification is there, which we can use. And after you do note all these TNM classification, you can now group them into various stages. So you can stage whether stage 1A, stage 1B, 1C in that order, or you can group them as stage 4A and stage 4 1B. So it's important that we keep in mind that majority of lung cancers will present in if we don't diagnose early, we don't have high index of suspicion. Prognosis is poor. So let's increase our index of suspicion. As I said, my other colleague will speak to what we should look out for. Refer these patients quickly to the centers where there is where treatment can be given or proper diagnosis can be given, staging can be done, and the MDT will decide on. So these are my references, and thank you very much.
Very much, Dr. Vishnu, for this very clear talk on giving us more like an overview of what lung cancer is. And I'm very grateful to you for keeping to time as well. Or just chat at the end of the both presentations, will address each question and ensure that everybody has the best understanding that is possible. Without wasting Barry, Dr. Pascal is also a fellow trainee in pulmonology. He is also very knowledgeable in lung cancer. And in fact, one of the main people or doctors behind our lung cancer MDT, very instrumental in putting our cases together. He's also going to take us through the importance of early diagnosis in lung cancer. And I would like to invite Dr. Pascal. Please share your slides. Thank you.
The day starts. Can my slides be seen? Can I be heard clearly?
Yes, we can.
All right. Okay. Sorry if there's some background noise. It's raining heavily where I am. Like they said, my name is Dr. Pascal Kambere, and I'll be taking you through the second part of this presentation. And we'll be talking about the importance of early diagnosis in lung cancer, mainly focusing on recognizing lung cancer early, so that we can, as the Dr. Abayate said, the later you make the diagnosis, the worse their prognosis. So as mentioned earlier, this is the disclaimer saying that AstraZeneca does not bear any responsibility of any faults if I misrepresent myself, and they are not trying to influence prescription trends. So this will be the main aim of the presentation. We are going to understand and look at the current state of lung cancer in Ghana, explore some of the factors that influence the incident, improve so just a brief overview of lung cancer. Dr. Vishnu covered this, but as we all know, cancer is the abnormal growth of cells in tissues and organs, and in lung cancer is abnormal growth of lung cells. And this usually causes a lot of health issues and problems that can lead to death. Lung cancer can present in various ways, and there are many types of lung cancers, most notably the non-small cell lung cancer, and then we have the small cell lung cancer, but we have different types. These are the main or the two majority. Lung cancer grows a bit more quickly, it's a little bit more aggressive, and that one is strongly associated with smoking. As I mentioned, smoking is a risk factor for developing lung cancer, but it doesn't mean that everybody that smokes develop lung cancer. People who have lung cancer, about 80% of them have a history of smoking. But then, as mentioned, there are other non-smoking related risk factors that we'll look at later on. So lung cancer is often diagnosed at advanced stages because most of the time it can be asymptomatic, and then when it starts presenting with symptoms, patients have already in with advanced stages. Like Dr. Ifeanyi mentioned, there are novel treatments, but some of them are indicated when you have early diagnosis. Now, it is the leading cause of cancer-related deaths worldwide, and it accounts for the highest mortalities above men and women. And we'll just look at a bit of the data in both international and in our local setting. So looking worldwide, looking at the Global Con Registry as of 2022, we can see that if you look at the top 5 most lung cancer is a leading diagnosis that was made as of 2022. And in females, it was second to breast cancer, where breast cancer was a leading cancer that was diagnosed in that period. But when you combine both genders, lung cancer takes the lead as a leading cause, leading diagnosis of cancer as of that year. Now, if you look at the ranking of the various cancers and then the mortality attributed to them, you can see that lung cancer, which is the first row, you can see that that was the #1 diagnosis made in terms of cancer diagnosis in 2022. But when you look at the death attributed to it, it's also the #1 leading cause of cancer-related deaths worldwide. So breast cancer, which is #1 in females, when you combine both genders, it's still the leading cause of cancer, leading diagnosis of cancer. But when it looks at the cause of death, it's the 4th leading cause of death worldwide in terms of cancer mortalities. Prostate is #8, and colorectal is #2. Liver is #3. And these are some of the common cancers that we also diagnose in our environment. But in our environment, breast, colorectal, prostate, and as such. So it's just to show that worldwide, cancer is a global problem, and it's associated with a lot of mortality. Now, if you do the look at the age-adjusted statistics as of 2022, you'll note that if you categorize the patients in various ages like 30 to 40, etc., and you combine the genders, you know that breast cancer is a leading diagnosis of cancer diagnosis that was made in 2022, followed by prostate, and lung cancer was number 3 if you do the age-adjusted rates. But then if you look at lung cancer, the mortality associated with it, you can see that it was the number 1 cause of cancer-related deaths worldwide. And this goes to show you that having a diagnosis of lung cancer, it's important to recognize the signs and symptoms and make a diagnosis early so that you can give your patient more treatment modalities, more treatment options so that you can improve their survivals. So speaking of survival, if you look at the survival rates of some of the cancers compared to lung cancer, if you look at in some of the developed countries, if you look at the 1-year survival rates, you see that cancer like prostate has a more than 9% survival. Colorectal survival is not too good, but it's over 75% survival in the first year. But when you look at lung cancer, the survival is less than 50% in the first year alone. So survival, when you make the diagnosis, the chances that patients may make it, 50% chances that people may not make it the first year alone. And this is in developed countries where they have more resources, more treatment modalities. Now, if you fast forward that in terms of cancer survivors, again, lung cancer 5-year survival is even less than 20%. It shows the poor prognosis that is associated with these cancers, and hence why it is important to diagnose and recognize these cancers early so that necessary interventions can be put in place for the patients. Again, looking at the survival rates in different countries, this was in the UK, and you can see the various cancers, and you can see that looking at the top 15 cancers that were in their registry, you can see that lung cancer is about number 12 in terms of 5-year survival rates. So it connotes that compared to other cancers, lung cancer is has a poorer prognosis, and hence why we need to tackle it as early as possible. Now, what is the state of lung cancer in Ghana? Is it the same as the global? We know that, as we mentioned, smoking is one of the most common risk factors associated with developing lung cancer. But if you look at Ghana in itself as a nation, it is not really known to be a smoking nation compared to other countries, European and Western countries where smoking is more prevalent. Ghana, smoking isn't as prevalent. So if you look at the top frequent diagnosis of cancer, again, from the Globacon 2022 statistics, you see that in both men and females, cause lung cancer diagnosis. You can see that it's not even in the top 5 cancer diagnosis in both male and females. But if you look at the where it falls, you can see that lung cancer its incidence was ranked number 10 in Ghana. So it was a 10th leading cancer diagnosis that was made in Ghana as of 2022. But also, if you look at the mortality associated with it, unlike the international stage worldwide, where it is number 1 leading cause of cancer death, in Ghana, it's ranked number 9. So it's the 9th leading cause of death in Ghana. And it's the 9th common diagnosis, cancer-related diagnosis. Number 1 being breast cancer, followed by cervical, prostate, and then we also have non-Hodgkin's lymphoma, which was number 5. But lung cancer in Ghana isn't something that is frequently diagnosed, and there isn't a lot of mortality. It was ranked number 9 in Ghana. And if you also do the age-adjusted incidences, you can see that the top 15 cancers in Ghana, lung cancer again doesn't feature in the top 5 or even the top 10. It's around 12, with a very low incidence when you do age-adjusted rates. And then the mortality associated we saw in the previous slides, whereby worldwide lung cancer is a big problem in terms of survival and in terms of incidence. So the question is this the true state of lung cancer in Ghana? This was in 2022, but if we go back to 2022, to see whether this has by Lai et al. That was done in 2012 and published in 2014. They attempted to do like a population-based cancer registry, and they started out with a hospital-based cancer registry, and this was conducted in Confanoche, whereby they looked at hospital data, pathology diagnosis, private lab diagnosis of cancer to kind of see the types of cancers that were being diagnosed in that encampment. And you can see that at that, they had a cohort of about 253 people. And then you can see that the distribution of cancer by its type as of 2012 is similar to what we were seeing in 2020. We are seeing 2022 in the previous slide, whereby you have more female-related cancers being the most predominantly diagnosed type of cancer. And you can see that lung cancer, really, its diagnosis wasn't too high in that cohort of people in that time period. So the question is it that in Ghana, because we are not really a smoking nation, that it's true that we don't really have a lot of lung cancer, that indeed our incidence of lung cancer is very low, and is very low? And is it that we are treating our lung cancer cases very well, that there isn't a lot of mortality associated with it? Or is it that we are not actually recognizing these lung cancers, these lung cancers, and hence when people die from lung cancer, we attribute the cause of death to other diseases like TB. So that is a question we should always think about, that because of the low incidence, it could be that truly we don't have lung cancer, or we are not picking it up early, and hence why we have this pseudo low incidence in Ghana. So what are some of the in Ghana? If you look at other countries, developed countries, whereby they have population-based registries for almost every cancer. When a diagnosis is made, the patient is put on that registry for every patient, so that no patient is lost to follow-up. Patients get the added. If you look at our healthcare system, making the diagnosis, one, is a bit difficult. We may not have all the diagnostic modalities. Two, we don't really have laid down pathways. We don't also have registries, lung cancer registries everywhere. There are some that have been attempted, but it is not a national thing. So when a person makes a diagnosis of lung cancer, let's say in the district, and refers them to the bigger cities, to the tertiary hospital to see an oncologist, they may come, they are given a date that is 3 months down the line. And this patient may unfortunately pass on before they are even seen at the oncologist, where their data can be captured. They may be also lost to follow-up. So we may not capture these patients, and hence why incidences may be low, because of how our healthcare system is structured. And they come with laid down protocols for detecting cases, making the diagnosis of cases to meet the research program in Africa and Ghana that we research into. There's also limited screening and diagnostics. If you look at other process to help screen patients, and these you can specialties are not everywhere, are not readily available in every part of the country. And then the screening modality, which is usual by low dose CT scan for developing lung cancer, and hence we may be losing some of these patients because they are underdiagnosed, they are not followed up. We don't have proper screening modalities. But I also believe that it's also because we are not making a lot of noise about lung cancer. Again, if you have to take other cancers like breast cancer, prostate CA, if I'm to ask everybody what month is breast cancer awareness month, if I'm able to say that for prostate CA, but if I'm to ask how many of you know which month is lung cancer awareness month, what are the colors that they wear on for lung cancer awareness month? Most of us will be scratching our heads because a lot of noise is not made about lung cancer and other groups of cancers. If you take breast cancer, there are walks, there are talk shows, people are interviewed, a lot of noise is made, outreaches are done, screenings are done, but not so for other cancers like lung cancer. And hence people don't think about it and don't think it even exists because a lot of noise is not made. And this problem, interestingly, is not unique to our setting alone. If you look at other countries like the UK, whereby they did a survey to look at the media publications about certain cancer before the awareness month and after their awareness month, and they looked at this data in 2011 and 2012, and you can see from the column A for breast cancer, which their color is pink, as you can see here, and their awareness month or close to the time of the awareness month for breast cancer. And as of 2022, the peak was high. But then if you take another cancer like lung cancer, yes, there are some peaks, but it's not as notably high as other cancers like breast cancer. And you can even see that some of the peaks do not even occur on the awareness month, like November, which is lung cancer awareness month. You don't have these peaks in 2011, and even in 2012, you didn't have the peaks. But you do notice some peaks for that for the other cancers. What I found interesting in this paper was that they mentioned that some of the peaks that you see before or just after for something like lung cancer, prostate cancer, is when a popular celebrity dies of that condition, that the newspapers now start making noise about that condition and start publishing it more and then create awareness. But after a while, the news will fade because it's not a popular kind of tumor. Nothing is heard about it again until someone famous dies. Not that we are hoping that a famous politician or someone famous will die of lung cancer before we start creating awareness, but we need to do more in raising awareness of lung cancer. Now, what can we do as clinicians in some of the things we can do as healthcare professionals to be able to increase our index of suspicion and increase our diagnostic yield of lung cancer? And one of these things that we can do is by, first of all, recognizing how it presents and recognizing the common risk factors that are associated with lung cancer. So in terms of risk factor, as we mentioned, cigarette smoking is one of the major risk factors for developing lung cancer. And as I mentioned, 80% of people who have lung cancer worldwide have a smoking history. But then keep in mind that you may not necessarily smoke, but you may be exposed to secondhand smoke. So maybe your spouse, your loved one smokes in front of you all the time, and hence that is your exposure. Maybe where you work, your co-workers smoke in front of you, and that may be your exposure. And you can also get exposed to smoke, not necessarily tobacco smoke, but based on the type of work you do. People who smoke fish, fishmongers who are smoking fish all the time, they go, and then hence they are exposed to smoke on a daily basis. The person who sells your kebab always exposed to smoke on a daily basis. So it's not only that when you're taking your history that you ask, do you smoke? No, and you end up there too. And don't forget that it's not only cigarette smoking that people do nowadays. People are now smoking marijuana and then weed, and this has been also closely linked with developing lung cancer. And when it comes to shisha, again, if you are to look back about 10, 15 years ago, before you wouldn't see shisha being smoked in Ghana, you wouldn't really see cigarettes being openly smoked. But nowadays, you tend to see that more and more, and that is seen more in the youth. And because people have the perception that shisha smoking is very harmless, because the smoke passes through the water, and then people believe that all the carcinogens in this smoke shisha. But contrary to that, shisha smoking is a major problem. Now, if you look at this study that was done by Fiamet et al., that looked at the state of lung cancer in Ghana, this was published in very recently. They cited a survey that was done between 2000 and 2017 to look at the smoking habits of the youth. And you can see that the prevalence of the smoking habits is not that large, and it has steadily declined over the years to 2017. Because, like I said, Ghana isn't in this study that I noted was that shisha smoking as of 2017 was a bit prevalent in students who were surveyed, and about 5.5% of the students surveyed at that time had admitted to smoking shisha in the past 30 days, 1 month. Now, you may be wondering why the big deal I'm making about shisha smoking is labels that many people are not aware of and do not see when they go and buy the shisha. And it's always clearly written in the packets of the molasses that it is harmful to your health and it contains nicotine that is very addictive. But most interestingly enough, a study that was done by WHO in 2015 showed that for every session of shisha, so one session of shisha, which usually lasts about 20 minutes to 1 hour, is equivalent to 100 cigarettes. So there are 20 cigarettes in one pack. That means once you twice a day, that means they smoke 10 packs of cigarettes in that one day. Hence why it is important to highlight here and note that the youth that are of lung cancer. Apart from smoking, other risk factors that you should look out for when you're discussing with your patients is that put them at risk of developing lung cancer, includes apart from COPD and lung cancer sharing a common risk factor, which is smoking. It's been noted that 20% of people who have COPD who never been smoked have a higher risk of developing. You also have air pollution. People are always burning refuse and a lot of other chemicals, and trying to get on a normal daily basis, you may be at risk. As I say, usually you tend to have it happening in the 5th to 6th decade of life, and hence it's also one that we mentioned those who work with firewood, charcoal, and smoked fish and other things that expose them to smoke. They are also at risk of developing lung cancer. And as Dr. Vishnu highlighted again, there are genetic abnormalities that can increase your risk of developing lung cancer, malignancy, and getting radiotherapy, and that may increase some of your risk for developing lung cancer because the lung can be exposed to some of this radiation as well. So it's not an exhaustive in with some of these risk factors. You should include lung cancer as part of your differential diagnosis. It should heighten your pick up your ears to think about lung cancers get treated for pneumonia. They'll go back 2 weeks later, they come back. Still coughing, they're treated for what they have, and depending on the clinical situation, you should include it as part of your differentials. People with lung CA also have, so you should also look out for these patients once they are in front of you at your clinics. Usually the tumor may be occluding one of the bronchos. It may be causing something to the lung parenchyma, and that can lead you to develop pleural effusion. And that, as we said, sometimes lung cancer is asymptomatic, and the first time people may present maybe is when it has spread or becomes more advanced, and then they can present with jaundice. If it's cancer can spread to the brain. And importantly, you tend to see some of the patients coming in with some form of bone pain, either in the shoulder, either at the back, or either at the chest areas, and then they present for the first time with bone pain and nothing else. You can also have hemoptysis, whereby the tumor either invading into the lung parenchyma or into a blood vessel and spreading into the pleural space and come with recurrent pleural effusion. You drain, they go back 3 days later, the fluid has reaccumulated. So for such patients, also intake them appropriately so that you do not miss out these patients as well. Now, if you look at in Ghana specifically, some of the ways in which lung cancer can present, Dr. Vishnu mentioned this, so I'll just highlight this graphically. In the 3-year review, retrospective review done by if you the main presenting complaint, whereby 60% of the people of that cohort had cough, followed by chest pain, breathing. But what is interesting is that if you look at the cough specifically and the duration in which they had before they even presented the first time to the clinic, you see that majority of the cases, again, to having their cough. So people will tend to have a chronic cough for a long period of time, always entertain the possibility of lung cancer, because most of them will have a chronic cough that lasts over a couple of months. So always have that at the back of your mind. Comes with a chronic cough and some of the symptoms of breathlessness or hemoptysis, they'll be treated for tuberculosis a couple of times before we even entertain any other diagnosis, but always add the possibility of a malignancy, a special lung malignancy, to these cohort of people you are seeing, so that we do not underdiagnose our population with lung cancer. Now, we'll just look at some few cases. As Dr. Efie Mensah mentioned, we do have a MDT, and which we started last year. And this is just to show you some of the ways, further illustrate some of the ways that these the cases that we've seen over this 1-year period has presented. And so that wherever you are, when you see such cases or similar cases, it should also increase your index of suspicion of thinking about lung cancer. This is very brief. So we had a 45-year-old female, no known chronic illnesses. Again, chronic cough, pleurisy chest pain, difficulty breathing. She was later worked up and then showed that she had a mass in the right, confirmed. We've seen a 74-year-old. This was a female who had a 6-month history of had been to various facilities, managed for pneumonia about 4 times before a chest X-ray was done that showed something on the left side, and then was referred. And the CT scan then showed that she had a mass that had extended into the anterior mediastinum. Also a 74-year-old male retired military personnel who came in with a 55 and also had a family history of colon CA, but he had an 8-month history of intermittent cough. And as if you can cast your mind back, he has some of the risk factors that we said predispose people to developing lung cancer at 1 day age. He had a significant smoking history. And we also mentioned that COPD, which emphysema falls under, is also an independent risk factor for developing lung CA. So you see that these things that these risk factors are out there in our communities as well. And then he came in with an 8-month history of a chronic cough before his chest X-ray was no female. Again, you can note the ages always in the latter decades of life.
Pascal.
Yes, please.
Thank you. Please, you have just about a few minutes more. Thank you.
I'm almost done. 74, the only exposure was that she sells, she's a food seller and it's always exposed to firewood, housewife. Was what she was exposed to. We had some that has been treated for sputum negative TB for over 5 months before someone decided to do a pleural fluid cytology, which showed malignant cells, and that prompted them to do a CT scan. And similar to someone else who was treated for TB for a while, and they decided to stop the medications because they weren't getting better and presented elsewhere, where they were investigated and then lung cancer was made. So we've seen some of the cases, and when should you refer some of these with recurrent symptoms that you are treating and they are not getting better? Maybe you should consider lung malignancy and send them, refer them to a cough and saw a mass, or interventional radiologists to do a biopsy. Them will do the biopsy so that we don't lose these patients. Also to facilitate treatment. You've made the diagnosis of lung treatment because survival is poor. We also to get these patients the necessary care as quickly as possible. And finally, evaluation of pulmonary nodules that we haven't talked about, but later on in the series we may highlight, is that pulmonary nodules may be a precursor to the development of lung cancer. So pulmonary nodules, you want to send them over so that we can evaluate these nodules, do surveillance if necessary, or do a biopsy if we can, to make a diagnosis so that we can confer them the necessary treatment. So where do you fall in this? Our important job is to identify them, because if we cannot identify them, we cannot even do the necessary biopsy and investigation. We cannot even send those samples for pathology to even confirm the diagnosis, or even do molecular testing for treatment to begin. So as healthcare workers, we are the first line in identifying and then diagnosing these cases, therefore have a high index of suspicion Even though incidence is low, it may be higher because we are not really diagnosing these cases. So always have a high index of suspicion when you have patients with recurrent symptoms. If they have been treating them for sputum-negative TB, they're not improving, think about lung cancer. Added to the patient as part of your differentials. And also look at other risk factors beyond smoking. Don't as well. Thank you.
Great. Thank you very much, Pascal. Really taking what has been shared this afternoon. We will move on to our interaction time, which I find very, very necessary as to how we evaluate our patients and when do we move them on. There are a lot of questions in the chat box, but I see one by our own Dr. Efwa Komi, which is very critical. And it says that beyond awareness creation, what are some of the strategies that may be adopted at the primary health care to prevent late reporting? What are some of the strategies? So I would say that when Dr. Pascal was talking, he made a comment that there's a lot of fanfare with other cancers, but not so much for lung cancer. I think that is always a stage. When those others two were kind of coming up on the horizon, people thought that it wasn't common amongst Ghanaians until eventually we realized that awareness was created. A lot of cases were being diagnosed. They tried to streamline all the cases onto centers that could handle the disease, and the numbers were out there. So I think it's only a matter of time. Eventually, this is the stage of awareness creation, and soon over noise, because we have enough data to be able to whip up the public. So I would like us to address this question, and then we move on to others. Sorry. Yeah.
Yes, please, Prof. Do
Yes.
I read the question?
Is that okay? Is that okay for us to go on to the panel discussion?
Yes, please. Yes, please.
Yeah. I will start with Dr. Efwa Komi's question, beyond awareness creation. So yes, awareness creation is what we have begun with the lung series on lung cancer for non-oncologists. So this is one of the platforms. But beyond this, what is our message for our listeners to improve or to prevent late reporting? Let me take Vishnu. Let's take your point.
Thank you very much, Prof. So I think the first step is the awareness. So we let people know that as the part of the differentials for patients presenting with respiratory symptoms, we should always have lung cancer at the back of our minds. With respect to the strategies, I think one of the challenges as a unit we've noticed is that a lot of patients that usually are diagnosed with lung cancer probably would have had 2 or 3 treatments for even for tuberculosis because of the persistent nature of the respiratory symptoms. So I think we want to make sure that the clinicians seeing some of these patients. I recall one of a discussion that we had. We were suggesting that if you have a patient that you make is negative, so you don't have gene expert positivity, it will be important for such patients either not necessarily even referring, but you can call what they think and whether there is a need for imaging to be done or not, so that those patients will not end up taking TB treatment for 3 times, 4 times. They are not getting better before somebody will now decide that they are going to move on to the next stage. So I think that's one thing that we can look at. So such patients, before you go ahead to treat for smear negative PTB, discuss with somebody in the pulmonology space so that they can guide you whether you should send the patient over or you should do some imaging before you go ahead with the treatment. So that's one I would suggest that we can look at to help in picking up the cases.
Thank you very much, Vishnu. Pascal.
Yeah, so yes, I concur with my colleague, Prof. Thank you for the opportunity. But you know, if you look at the number of pulmonologists to the coverage of Ghana, not everybody may know how to contact a pulmonologist. That may also be one challenge. So I also think, in addition to that, if there are designations, let's say in the Western region, if you think there's you've made a suspect lung cancer, somewhere you can send to channels. Or you can also have what I think maybe setting guidelines or protocols that if you are, like you said, treating someone with TB, they're not improving, the next step is to get a chest CT scan or something, or refer for further evaluation, so that no matter where you are, you know that these are the steps I need to take when I'm dealing with this respiratory condition, and that so that we don't lose some of these patients as well. Because sometimes we treat pneumonia or we don't send them early because we don't have the imaging capabilities where you may be. So if you have patients, they're not getting better, and there's laid down protocols, you know where to send them. I think that will also help as well.
Yeah, thank you very much. So I would say that these are very important points to note. But again, just to summarize what they have said, kindly listen very well to me. We realize the biasness of TB diagnosis, and so definitely there's going to be a lot of education engaging TB centers. But we also know that our doctors in the community are very important, because patients always present to these centers before anybody suspects them to have a condition like lung cancer. So kindly, one, have you seen any patient with an abnormal X-ray? What were your thoughts? Did you think that the patient could have TB? You've gotten your results. It's TB, it's GeneXpect negative. Are you comfortable with a chest X-ray and know what is happening? If not, we beg of you, kindly refer the patient up to a specialist who may be able to interpret and ask for further investigations. Would have said that, okay, send them to a respiratory person, but they are not in the system and can't cover everywhere, but there are physician specialists in various centers that you can reach. Now, if you thought that this is not TB, or you got your GeneXpect and it's negative, so you concluded that, well, I've seen a consolidation on the chest X-ray, so I think this is pneumonia. Perfect. Go ahead and give your treatment for pneumonia. But what we say is that in a certain category of patients, in fact, per guidelines, once you confirm that somebody has a pneumonia based on X-ray consolidation, after 6 to 8 weeks, you are encouraged to repeat the chest X-ray to see whether this consolidation has resolved, especially in patients who are above 50. Because lung cancer can also present with a persistent consolidation. So let's take note. If you do treat consolidation, you've seen that that's what's on the X-ray, it's a pneumonia, you've gone ahead. Kindly remember, particularly in the elderly, to ask for a repeat chest X-ray. And if this is not non-resolving, please move them up and get further input. Coin lesion on a chest X-ray, we also would plead with you, please refer this patient up. by the end of the presentation, we'll put up numbers so that if you do have any case that you are worried about, you've seen a mass, consolidation, we ask that you repeat in 6 weeks if you thought it was a pneumonia, but if you thought it was a nodule, you thought it was a mass, would also give some numbers at the end of the presentation so we can reach us. Therefore, I hope that this summarizes the other strategies that we can put in aside as creating awareness to help patients get to the right center. Thank you. Thank you, Doctor. Since smoking prevalence is low, I think there's lots of risk factors. For us, it's more environmental and pollution. Okay. I remember the first study we did, we saw that a lot of teachers, amongst those who had it were a lot of teachers. As to whether there was anything in their job predisposing them, I don't think so. But again, it's interesting to note. But we have more of environmental pollution, and so we should look out for that. There's also a very big area of risk factors that we possibly have not identified, and it could also be genetic. Great presentation. Please, do we typically see early stage disease in Ghana? What are the barriers to early diagnosis? Can any of the presenters answer this for me? Thank you.
Okay. So most of the cases that we see usually present in the advanced stages, usually stage 4. This was highlighted by Dr. Vishnu by a retrospective study that was done by FEMS et al. That looked at some of the presentations of people who came to the respiratory clinic, and those with lung cancer, usually most of them, about over 80%, came in at late stages as well.
Okay, perfect. Perfect. I think some of the barriers are what we have stated: late recognition at the primary care setting, late referral along the cascade of healthcare sectors, and then a chronic cough that you've seen on and on and on and on, and treated for pneumonia. Almost every time they come, they give them antibiotics. We'll plead with you, maybe ask for a chest X-ray. We also realize that the inertia for requesting chest X-ray is sometimes low. Let's try and do that, especially when we've had a case of a chronic cough or somebody complaining about some chest pain that is worrying. Let's a chest X-ray when things. Question that says that, Doc, please, is the lung cancer registry still active? How can we improve data generation and capture true incidents? Pascal, can you give us this?
Yes, it's very much active. We meet almost once a month currently on a Friday, I think the last Friday of every month, and we discuss all the cases we've seen through the month. We get cases coming from a lot of places, Upper West, surrounding eastern regions, Takwa. So if you have a suspected case, sometimes they are sent, we evaluate, we confirm the diagnosis. Sometimes the diagnosis is made, so we capture their data, also facilitate them getting the necessary treatment they need by shortening the time they have to wait before they see the oncologist. So yes, we are very active.
Thank you. I'll go on to the next question. This is one colleague of ours, Ernest Dramina, asking, what are some of the chest X-ray findings of lung cancer? I think this is very important. Can anybody answer? Maybe the second speaker, and then we can take it from there.
So there are various presentations, like Dr. Ifeanyi mentioned. Some of them can look like a persistent consolidation. Some of them can look like a coin lesion. Some of them may be what looks like for lack of a better term, a mass. Some of them may be irregularly shaped mass. Some of them actually can present as a thickened, what looks like a thickened pleura on the chest X-ray, and then you can see it on a CT scan. So it has various ways, but usually you see most often what looks like an obvious mass. Sometimes it's well defined, sometimes it's not. And then if you also have a persistent consolidation, usually if you get mets from other places, you may see what looks like cannonball lesions as well on the chest X-ray.
Able to develop an algorithm or a flow chart on diagnosis based on signs and symptoms and basic imaging like X-ray.
It's possible. So maybe we can look at it as a team and put something together for circulation to our colleagues. So I think it's something that we can work on.
That's good. Thank you. For a differential diagnosis between TB and lung cancer, are there any specific diagnostic tests to request to give you precision?
Thank you, Prof. So in terms of the presentation, the TB and lung cancer, some of the symptoms are similar. So you can have cough, you have both cough in TB and lung cancer. You have hemoptysis in both TB and lung cancer, weight loss. Okay, so in terms of symptomatology alone, it will be very difficult to say that, okay, you are dealing with TB or you are dealing with lung cancer. So for instance, if it's TB, and you do your microbiological test like GeneXpert and it is positive, and also your imaging, you look at the imaging and to be able to distinguish between the two. But even though chest X-ray is an initial preliminary investigation that you do, but for the diagnosis of lung cancer, you are looking more at doing a chest CT scan. And if the patient doesn't have any contraindication, then you are looking at doing chest CT scan with contrast. So I think I recall at some of the MDT meetings, we have patients who were referred as lung cancer, but then they came in with plain CT scan, and we were wondering why the patients didn't have CT scan with contrast done. So if you suspect that a patient has lung cancer, then if you are requesting for imaging, then you should request for a chest CT with contrast. So that can help you in identifying whether there is a mass, is it enhancing on the X-ray. Then from there, you can go ahead and plan for a biopsy.
Thank you. So I would like to add that, yes, sometimes it can be very confusing, especially if it's a consolidation. And with what they call the bronchoalveolar kind of carcinomas, that was the previous name for that. Now again, your history may help if there are risk factors that you have identified. And you find a mass-like lesion on top of your differentials, whilst PTB is on the lower side, and you would ask for a gene, look like fibrotic changes that look like bronchiectasis, then it more or less points you towards TB rather than a malignant lung condition. But again, we will say that just as TB does not have pathognomonic features on chest imaging, it will be difficult to just look at it and say that, no, I think this is TB and this is lung cancer. So other investigations would always be very important. I would like to throw in this question before I take this. Pascal, you made a point that we can a situation where, let's say, you've had a chest, asked for a CT scan, And we want to encourage that if you see a mass, then ask for a CT scan with contrast if it is not contraindicated in the patient, because that's helpful. Otherwise, they do the non-contrast, and when they come in a lung mass, would you advise that, I mean, from the community setting, or pick doctor in another hospital or in a private facility, would you advise that you send straight to, let's look at the benefits and the downside of such activity? Thank you.
Okay, so thank you for that. So yes, you've seen your mass. We haven't really confirmed so it would be good, one, to send to the respiratory clinic first of all, so that one, apart from capturing them, they can also be followed up by the respiratory physicians. The other benefit of that is that, as we mentioned, there's an MDT that can also facilitate treatment and all those things. And sometimes if they haven't had their biopsies, we can sometimes biopsy it ourselves or let the radiologist biopsy it. So it kind of cuts down the delays. Sending them directly, yes, you can also do that, but sometimes they also get lost in translation. By the time they come, get booked, and then especially if they are coming to, let's say, the tertiary facility for the first time, they can become very frustrated sometimes because they don't know exactly where to go, what to do, and we kind of help with that. So you can send them directly, but then it also causes certain delays. They'll give you your biopsy, send you the report, and now you interpret it, then now refer to respiratory clinic. So we kind of help reduce the back and forth a bit and kind of guide the patients on what to do and aid them in these things. So it'll be best to send first to the respiratory clinic, and then we take it from there.
Thank you. I ask this because, I mean, it's always maybe I'm somewhere in Koforidua, or I'm somewhere in the outskirts of Accra. I've done the CT in my facility. I've say Kolebu radiology for biopsy. The benefit of this may look like, well, I'm just cutting across and sending the patient directly, but what happens? Patient sends the sample is sent for histopathology. Sometimes the patients collect and show it to you before you send back to the oncologist. Then it means that more or less you've cut out probably maybe the respiratory clinic. So I biopsy myself, I send straight to the oncology. Significant delays along that line. Whilst if it is, we have our own discussions with the biopsy sites. If it's bronchoscopy, we know how to push and get it done. When results are ready from the pathologist, there are always linkages with the pathologist from the MD. So the patients also don't know they have to go and collect the report. It will be sitting there, and there are a lot of make significant progress with lung cancer care. It's how to shorten these cycles. You need to go to the oncology clinic. We have a schedule for you. We can fast track this. You don't have to wait for 3 months. And so, in as much as people will want to do that, we just don't go for the report, and they are not accounted for. So if we want to build our databases, then we would ask that, as is done elsewhere, there should be more like a also see lung cancer and refer straight to the cardiothoracic surgeon. I mean, that has been the norm for some time. We are working closely with them also, but what is the need for that one? But let me also say that the MD is made up of pulmonologists, pathologists, oncologists, cardiothoracic surgeons. So we quickly have them on board. Can you operate? Yes, we send them through. Rather than they also move on to this, should there always be a mass-like object on a chest X-ray before you can suspect lung cancer? And sometimes it's just an area of opacity. It's just an area of opacity. Some are solid, some are non-solid. So if you have detected any such on the chest X-ray and you're not happy about that, ask for a CT. The moment you see what is suspicious, please move on to those who can help. Thank you. Can a person develop PTB and lung cancer at the same time? And how can the clinical features manifest? Vishnu.
Yes, so people to develop TB and lung cancer together. The prevalence of the coexistence of TB and lung cancer is not being studied widely, but globally it's estimated between 0.9 to 13.7% in some studies. We've already spoken about how the presentation and the fact that they can be similar and what you can do to be able to distinguish between the two. So the simple answer is yes, they can exist together.
Okay, thank you. And I would say that at the chest clinic, I think over the past 2 years, we've had about 5 cases where they were confirmed to have lung cancer. Very tricky one. The patient was diagnosed with gene expert, forget about everything, but the patient was not doing well. Or they referred to chest clinic, thinking that it could be MDR TB, and a CT scan picked up an associated mass. That really delayed the patient. We lost the patient anyway. But this is also one of the reasons why we want to engage the TB centers. Then somebody asked, interesting question from prevalence of TB. I throw this to the jury. Anybody from the group? Participants.
And Prof, I think they are unable to unmute.
Oh, they are. Okay, we can type. We can type on.
Type.
So was it because female population and most women teachers were males anyway? I don't know how that works out, but it is some research has ever been done to show. Does chalk contain talc?
No.
I asked my panelists, does chalk contain talc?
Not that I'm aware of, but maybe they also shared maybe similar risk factors.
Yeah.
Yes, as well, apart from the teaching, maybe they lived closer.
Yes.
Endemic area or something.
But we know talc can sometimes be one of them. So I don't know. We'll find out whether there was anything like that. Great presentation to our speakers. It's presentation between e-cigarettes, vapes, and lung cancer. Vishnu, can you answer this for us?
Association with smoking, vaping with lung pathologies. People tend to sometimes develop ARDS, and then they can also get some form of fibrosis as well. direct link to lung cancer. Well, vaping hasn't been in the space for a very, very long time as compared to cigarettes. It's a new trend that has been coming up. But what they have shown is that sometimes it's very hard to determine because, you know, the things they put in the e-cigarette or the vaping pen, when they light it up and it combusts, it also produces a lot of other chemicals and toxins that are usually not detected when it's not combust. And they've seen that some of these chemicals and toxins are carcinogenic. But again, it hasn't been studied for a long period of time to see whether there's that direct association. But theoretically, yes, there is a possibility, but there hasn't really been much link. But it has been shown that it can cause respiratory problems, lung damage as well.
Okay, let me add that, well, there were some studies that the basic thing about cigarette smoking is nicotine, plus the other harmful substances in the cigarette. E-cigarette was actually done to help smokers who were having challenges quitting, and more or less to step down. So it's like, well, you do a lot of cigarettes, let's try and see if we do the E6, it will help you step down, and then slowly you'll be able to quit. And then secondly, they found that it was a bit more environmentally friendly in terms of what it's put out there. But some studies have shown that it is not so. And let's not forget that the e-cigarettes too comes in doses. Some are actually 6 milligrams, some are 12.6, some are as high as 18 milligrams of nicotine per let me use the word pen. So it is not that innocent. And then what it was meant for was to help people move from one stage of trying to quit, but they realized that it didn't solve that problem. And vape also does contain about 40 milligrams of nicotine per 2 mils. So I think it's very similar to what happens in the shisha picture. So they are all carcinogenic. Thank you. And then we have Anonymous says, Anonymous attendee, wonderful presentations from our speakers. Please, are there any established current treatment protocols in Ghana for lung cancer? Excellent. There's a very good question you brought up. There are. I would say that currently we have the conventional chemotherapy, which is what we have always had, the platinum-based therapies, combined therapies. We have seen over the years that they don't really help. Survival sometimes 6 to 12 months. But now there are new lung cancer therapies that have focused on the mutant strains that the speakers were talking about, EGFR, ALK, and those give wonderful results. If you are lucky to have that mutation and you have the money to pay for those medications, you can reduce lung cancer to like a hypertension treatment. And I would say that there are protocols. We just have to identify these patients early. And one of the curative intents is surgical. So if we can pick them early in stage 1 and 2, or maybe, yes, let's say stage 1 and 2, we have excellent results with surgical excision. Thank you. What is the prevalence of TB lung coexistence? This is from Bashir. We have said something to that effect. Thank you. We said that it can happen. The next question is it possible to have TB and lung cancer? Yes, people are asking this. Let's say it is possible. If yes, when your patient has sputum positive TB, what would will make you go ahead to investigate lung cancer? That is why patients on TB treatment, we know the effect of TB treatment. If it is truly TB, by month 1, patient starts recovering. They start doing well. Their appetites improve. They start gaining weight. But if you have a patient on TB treatment who is not doing well, by month 2, you should start asking questions. You should start feeling that, well, let me move this patient on. Even though the patient is maybe gene expert positive, let me move them on. Particularly so when it is smear negative, kindly give a referral. We'll be happy to assist in that vein. Rather than continuing, stopping, chronic patients, they complete 6 months, the cough is still there, they start another 6 months therapy, and patients have been on multiple TB courses for chronic cough that has been gene expect negative. We plead that that would also be revised. The other question is, please, what is the general timeline for lung cancer progression from initial development to metastasis? Vishnu, can you help us?
Thank you, Prof. So, I mean, generally, it will depend on the type of lung cancer. And as we've said in the presentation, most of them, even at the time of presentation, will present with how they call it, metastasis at the time of presentation. So cancer generally, you are looking at between some, if you take, for instance, small cell lung cancer, you are looking at within some few weeks to some few months, okay? And also the same for lung cancer, you are looking at within some few months. So without intervention, you are not looking at a very lengthy period of time, averagely around 3 to 6 months, you may have metastasis. And if it's small cell cancer, it may even be earlier than that.
Yes, thank you very much for that. In fact, literature says that most patients who are diagnosed with lung cancer, about 80 to 90% of them, 70 to 80% of them would die within 1 year, no matter the type of lung cancer. But of course, when you have small cell, progression is very quick, few months, weeks to months, but we never know when the thing started. That is why we are also now focusing on following up cases of pulmonary nodules, because some of them actually will progress to lung cancer. And if you have non-small cell, maybe the duration to metastasis might be a bit longer than if it is non-small cell. And more so with the kind of cancers we call the bronchial carcinoid tumors. Good. Somebody is interested in CPD. So this is Julia. Someone says that, is there any form to fill to get our CPD? I hope you have heard our discussions, and the CPD is only the side attraction. I hope so. This is from Lukman. Thank you. And then we have one question here. The challenge is that the patient will not be ready to go. Can there be some communication between the pulmonary clinics and health facilities? Can we have some portal for tracking these suspected lung cancer cases between centers? That is very true. I think some patients just don't want to move on to a referral facility, but we will put the numbers up. Vishnu and Pascal, can I beg you to put your numbers up together with that of Chris or Ernest, the clinic registrars, so that people can call. At the respiratory clinic, we have a policy that if you bring a referral of lung cancer, maximum within 2 weeks, we should give the patient a date of attending. We won't keep the patient waiting for a long time. So when you are writing your referrals, please write, if you are querying that, write query lung cancer, and then we make sure that we put them through maximum by the 2nd week they are seen. They are seen with that. So thank you, Pascal, Vishnu, Chris, and then Ernest. You can put those numbers up so that our colleagues can reach us at any point in time where we can help. I hope I have exhausted the questions. I have another one.
So I'm putting it in the chat box. Okay.
I'll be happy if you can quickly create a slide and project it. Or maybe, yes, maybe I'm IT a bit. Maybe they will pick it up, then that's fine. Then there's a question that says that this has been extremely informative session. A big thank you to you all. Thank you very much, anonymous attendee. Yes, I would ask for, whilst the slide with the numbers is being prepared, I would ask for closing comments, first from our speakers and then second from AstraZeneca. Thank you. Closing remarks, please. Pascal, Vishnu.
Yes, so thank you. So We are grateful to have had your ear for this period, for this fruitful discussion. And I hope the key points that we are trying to highlight here will you guys will pick it up. Just to recap some of them, that have a high index of suspicion for lung cancer, especially patients who have chronic symptoms that are recurrent, like a recurrent cough, a suspicious chest X-ray, you've been a recurrent pleural effusion, you've been treating smear negative COX, they are not getting better. Maybe if you include lung cancer as part of your differentials. Also look beyond smoking. We've highlighted some of the risk factors that go beyond smoking that some of the patients may have, especially environmental and occupational exposures. And don't be afraid to refer the cases. Sometimes it's more beneficial because we have an MDT team that may help facilitate the patient's diagnosis or treatment. Also, it goes beyond awareness, but also try and create awareness in your own place. Don't forget Lung Cancer Awareness Month. Hopefully, people now go and look at when Lung Cancer Awareness Month is, and just wear that shirt. When people ask, then you tell them, and it will also help create a bit of awareness.
Thank you. Thank you. Vishnu, I'm waiting for the slide.
Yes, I'm almost through.
Almost
But
through.
I would just say that lung cancer, we should look for it. Yeah, I mean, until you start looking for something, you may think that it is rare, but once you start looking for it, you come to the realization that probably it has been there with us all the time. So I will encourage all of us to always have lung cancer at the back of our mind when we are managing respiratory patients.
Thank you. Thank you very much. I would say that if you find anybody with an incidental pulmonary nodule, aside all that they have said, if you've seen anybody with a pulmonary nodule, they did a CT for whatever reason, and they found something they call a nodule, please, if possible, we are supposed to follow these nodules up, and there are lay down radiological structures that measures these nodules in a way so that when the CT is repeated and there are changes, we possibly would quickly have to act if they fall in that category. So please, let's take note. Pulmonary nodules are very good and early signs that it could be lung cancer. So it will help us detect and achieve stage shifting from 4 to maybe 1. That would be good news for us. Thank you very much. So this is the numbers that we want you to keep. And please call if there's any problem. If you want to send us a case for lung MDT, if you want to involve us in any way, you have diagnosed it, you want us to push it forward to the oncologist, please reach out to us. And this is only the beginning of the lung series for non-oncologists. Thank you for your time, and we hope to meet again. AstraZeneca, please take over. Thank you.
Thank you so much, Prof. I think it's been a wonderful meeting. I've learned so much just by listening, and I can feel the passion for lung diseases emanating from our speakers. I would just like to take the opportunity to thank the speakers, Dr. Vishnu and Dr. Pascal, and then a big thank you to you, Prof. Efriye Mensah, as well, for this wonderful talk. I just want to highlight that with the CPD points, I see some comments like the link is not working. Please, they're working on the link.
It's coming up plenty. The link is not working. Please fix it.
Yes, please. So we're actually working to get the link and then share with you immediately. And thank you so much for joining us. Really appreciate the time taken, and I really, really appreciate the questions that were asked. And I'm grateful that you could join. Going forward, we plan on doing more of such meetings as a series, looking at other aspects of lung cancer, including imaging and treatments as well. So please do look out for our invitation coming up, and we hope that we can make more impact in the space. Thank you so much, and please do have a good evening.
Bye-bye. Thank you.
Bye.
Right.
you.